Acute exacerbation of chronic obstructive pulmonary disease, COPD, refers to a worsening of respiratory symptoms that goes beyond normal day-to-day variations. This condition often requires adjustments in medication or treatment strategies. The primary goal is to stabilize the patient and prevent further decline in respiratory function. Primary risk factors for COPD. Cigarette smoking remains the most significant risk factor for the development of COPD. Additional contributors include genetic syndromes, occupational exposures, passive smoke inhalation, the use of biomass heating fuels in poorly ventilated areas, and exposure to air pollution. Understanding these risk factors helps guide preventive measures and early intervention. Differential diagnoses in acute exacerbation. In cases where standard treatments fail, clinicians must consider other life-threatening conditions. These include acute heart failure, pulmonary embolism, pneumonia, mucus plugs, and pneumothorax. Clinicians should also remain vigilant for potential lung malignancies in patients with COPD presenting with acute exacerbations. Accurate diagnosis is essential to ensure appropriate treatment. Cardiac arrhythmias in COPD. Common arrhythmias associated with COPD include atrial fibrillation and multifocal atrial tachycardia. Electrocardiogram findings may show P pulmonal, low QRS voltage, and poor R wave progression. However, these findings are neither sensitive nor specific for diagnosing COPD. Monitoring cardiac function is an important aspect of managing these patients. Non-invasive ventilatory support. Bilevel positive airway pressure, BiPAP, is an effective non-invasive ventilation method for moderate to severe exacerbations of COPD. However, this method is not suitable for patients who are hemodynamically unstable, markedly agitated, uncooperative, or in respiratory arrest. Careful patient selection is necessary to ensure safety and efficacy. Considerations for intubation. The decision to intubate should be based on the patient's clinical status rather than arterial blood gas measurements. Even with a significant rise in partial pressure of carbon dioxide, intubation may be avoided if the clinical condition stabilizes. Clinical judgment plays a key role in determining the need for invasive ventilation. Pharmacological management. 3 primary medication classes are used to manage acute exacerbations of COPD. First, bronchodilators such as albuterol, a short-acting beta-2 receptor agonist, and ipratropium bromide, an anticholinergic, are first-line agents. Their combined use may have a synergistic effect. Second, systemic corticosteroids, administered orally or intravenously, are effective. Intravenous administration is preferred for patients unable to tolerate oral medications due to respiratory failure or intolerance. Third, antibiotics are indicated for patients requiring intensive care or those with increased sputum purulence, dyspnea, or sputum volume. Role of magnesium sulfate and other treatments. While intravenous magnesium sulfate may enhance bronchodilator effects, current evidence is insufficient to recommend its routine use in emergency settings. Additionally, there is no established role for methylxanthines, Heliox, or respiratory stimulants in managing acute exacerbations of COPD. Treatment decisions should be guided by evidence-based practices. In conclusion, acute exacerbation of COPD requires a comprehensive approach that includes identifying risk factors, ruling out differential diagnoses, managing cardiac complications, and using appropriate ventilatory support and pharmacological treatments. Clinicians must rely on clinical judgment and evidence-based guidelines to optimize patient outcomes.
Thank you for watching. Please subscribe to our channel by clicking the subscription button. If you have any questions, feel free to leave a comment below in the comments section.